Hey there, it's time to take the lead. Trust your voice, know what you need. Let's break it down.
Welcome to Beyond Clinical Walls with your host, Dr. Bayo.
We'll claim your life.
If you've ever sat in a doctor's office and left feeling like something was still unanswered, this episode is for you. Here's something I hear more than I should. A woman notices chest pain, or she's suddenly exhausted, or she's short of breath doing things that never used to stop her. She finally goes to the doctor and she's told it's just stress, anxiety, or maybe she's just overwhelmed, or maybe she's not sleeping enough. And sometimes that can be true, but sometimes there's more going on, and clinicians feel that too. The system gives us 10 minutes, maybe if we're lucky 15, to have a conversation, examine, and do so much more that needs to be done, but it isn't always possible. Heart disease is the leading cause of death in women. Women who care deeply about their health, who show up to their appointments, who are doing everything right, and still nobody has walked them through what to watch for, what questions to ask, and what their own risks look like. When you have it, you can show up to appointments differently. You have a better conversation. You become a collaborative and informed partner in your care. That's what today is all about. I'm Dr. Bayo, a family medicine doctor and your health advocate. My guest is Dr. Kuria. You may know her from social media. By the time this episode airs, she will be freshly graduated from her cardiology fellowship at Loma University Medical Center, and I could not be more excited and proud to have her. Dr. Kuria, welcome to the show.
Dr. Bayo, thank you for having me.
So I'd like to start off with some rapid questions.
Let's do it.
What's one thing your patients would be surprised to learn that they should ask for when they see a cardiologist?
They should ask what is normal and what are their numbers. Every time they're given a vital sign, a lab value, even a diagnosis. Is it mild, moderate, severe? Because a lot of patients leave not really knowing their diagnosis or whether or not their blood pressure was normal. So just asking, what is normal? And then what are my numbers and where do I fall in?
That's a fantastic tip. So now, one heart healthy habit you wish every woman would start this week.
Don't stress the little things when you're trying to meet a goal. You want to eat right, you want to exercise, just pick one. And if you feel like you weren't able to meet it, try the next day. Don't try to do everything all at once, eating right, exercising, sleep. Just pick one and do that thing for that week.
I love that. Small steps can lead to big impact. Okay,
Yes.
If more women knew blank, heart disease outcomes would look completely different.
If more women knew that although heart disease is the number one leading death for women, it's preventable. And I think it starts with knowing your specific individual risk factor, not anyone else's, knowing yours in every decade of life. It's preventable, and we just don't start early enough.
All right, we're going to talk about prevention and what more people need to know. So I think a lot of women listening have had some version of this experience. Something doesn't feel right, but they start questioning themselves because somewhere along the way, you were told that it was probably nothing. And when that happens, you can feel less than. And when it comes to heart disease, we've just shared prevention is key.
Mhm.
So, Dr. Kuria, why did you choose cardiology? Because I am a big believer. There's a reason, there's a mission, and it pours out into our patients, especially when it comes into healthcare. And, what keeps you going?
I initially was interested in cardiology because I thought, I love procedures. I love working with my hands. I love talking to people. It really wasn't until my third year of medical school that I realized that cardiology was a space that needed me, specifically a woman, Black, immigrant, a child of the American dream. When I had a patient interaction where I kind of felt like I was the only one that was really advocating for this patient. I was a third year medical student, so I had just started clinical rotation. I was so excited to see patients. And I was convinced that this patient, she was Black, she really wasn't like elderly. She's probably like in her 60s. But I was convinced that she lacked capacity to make decisions. She came in complaining of like chest heaviness, but she wasn't calling it chest pain. And she was declining everything. She was declining lab, she was declining physical exam. And I remember telling my attending, I was like, I don't think she has capacity. He's like, no, she knows her name. She knows where she is. I was like, yeah, but she was like a prior professor. So it's really hard to gauge like these like educated women. It's hard to gauge when like they have like Alzheimer's or like dementia. And so I called her family and they were like, she has dementia. She doesn't have capacity. And I remember doing the mini mental test with her and she knew the day, she knew her name, she knew what year it was. But when it came to like the more difficult questions, like, okay, remember those 3 things I had told you about before? Like, can you name those 3 items? And like her mini mental score was so low. And I remember thinking, like, this is a woman who she needs cardiovascular testing and she's refusing. And we're just listening to her. But I was like, I called her family. She had like a medical power of attorney. And I remember thinking, like, if I hadn't really spiraled down this like rabbit hole and kind of being like that annoying medical student, I think she probably would have gone home. She would never gotten an echo. She would never got an angiogram. We never would have known that she had obstructive disease. And so I realized, like, oh wow, like I kind of felt like a nobody, right? You're a third year medical student. Who's gonna listen to you? That kind of stuck with me, and I kind of realized, like, oh, there's a space for me here. I need to be here because nobody else might do this.
There is a space for you, and cardiology definitely needs you. I had to write that down right when you said that. And that leads me to you and I. This is such a special podcast episode for me because having a woman of color and
Mhm.
having a Black woman as my guest, as a physician, makes my heart so happy. So we know that women of color have an even steeper gap when it comes to cardiovascular care. So,
Yes.
what would you like any woman of color to know about what they should expect when they see their doctor?
It's kind of a difficult question because when I think about why is it that women of color have the highest rates of all cardiovascular risk factors, high blood pressure, also known as hypertension, high cholesterol, um, worst rates of heart failure. Like, why is it? And it's so multifactorial that I even feel a little overwhelmed trying to think, how can I make that difference? And so I do what I can, as one person, and it's really the big thing to tackle is clinician bias. Everything else that's multifactorial is, socioeconomic, also depending on where you live, access to good food, access to good health care. And then, in some parts in the US, if you were to like overlay like a map of the United States, and there's a study that shows this, the highest rates of cardiovascular disease are really just like congregated in areas where there are more Black people, in the South. And so I think about some of their different cultural, socioeconomic issues, even things like, domestic violence, high rates of depression and anxiety. Those are all things that are really hard to tackle as a clinician. But what I can do as one person is that clinician bias and kind of dismantling some of the discrimination and racism that I know that like my patients are facing as Black women, even the ones that are in the workforce. And so the one thing I tell them is you really need to have an advocate. If you yourself don't have good health literacy, take somebody with you. Take your daughter or your son or your husband or your wife. Have that person with you, write things down. And if you feel like your doctor finds that to be too much, you need to find a different doctor. And I know that I say that coming from a place of privilege where, I know doctors. I can call my parents doctors, but I tell them like it's really sometimes going to come down to a clinician that listens to you. And so bring that person with you. I find that even in, the CCU, my patients who have someone in the room at all time, they do get better care. And part of that is I feel like it's an extra set of eyes. And that's so important for our patients who if it's just them, they may feel like, "Oh, like, I'm not being listened to," but the person next to them might be the one that speaks up and says, "How about this? What does this mean?"
Having someone by you makes a difference. And when you talk about the bias, layer that is so important to you, it made me think of the story that you led with, which was the Black woman who was declining everything. And if it wasn't for you to kind of step in there and go a little bit further and be like, wait, why is she doing this? And how the automatic, well, maybe she just doesn't want it, or maybe she just doesn't care, which where that lands with,
Oh,
which
mhm.
often
The
is associated
non-compliance. Oh
non-compliance.
my
I knew you were
goodness.
gonna say it,
Oh.
yes. And so, those are things that really do have an impact. So when we talk about women's healthcare, and today, of course, we're talking about cardiology, that is a huge piece. So now let's get into a couple of other things. When I think about information and how
Mhm,
quickly information changes, especially with social media, I would love for you to walk us through what a woman should look for right when she sets out to have an appointment with a cardiologist.
mhm,
What are different things that might help a conversation, especially when you're meeting a doctor from the jump, like from the
mhm,
first start?
mhm.
It can first feel intimidating. Something I talk about quite often is the power dynamic, where you, as the patient, you go in and you're going to see your doctor. You don't feel well. You are not sure what this doctor is going to say. Is this doctor going to help you? And that can show up in where you're not able to share why you're even there. And you could be the
Yeah.
most educated, the most well traveled, and this can happen. So, can you walk us through some of those things that someone could do?
Yes, I'm gonna start with the patient story because this patient taught me so much about what it's like to see a specialist. And I used to say, "Hi, I'm Dr. Kuria. Welcome to the cardiology clinic." And I had a patient look at me and just start crying. And she was like, "I don't want to be here. I don't want to see a cardiologist." And I realized, like, oh, this can actually be like really scary for some patients when they hear heart disease. They think like, I'm gonna die. I started off with this patient, like very gently, just asking her, like, what is your understanding of why you were referred? And so sometimes patients know, sometimes they don't. When it comes to women, what I've started doing is explaining, um, their risk factors. And if they're, 20s and 30s, I tend to ask more questions about, are they planning to have children? Have they had children? And then I kind of go over their pregnancies, which confuses them because it's cardiology. But I explain pregnancy is your first stress test. At 30 years old, it's unlikely you've ever had like a real true cardiac stress test. And if you go through that pregnancy without high blood pressure, gestational hypertension, gestational diabetes, or preeclampsia, you're pretty much like out of the woods. You pass that, first stress test. And when I explain it to them like that, they're like, oh, okay. They kind of calm down. And then from there, I say, if you see me once a year, we'll have this conversation. I'll ask you about, your lipid panel, your A1C, and your blood pressure. And these are numbers you should remember. If you know your shoe size or how many units of Botox you have in your forehead, this is a super safe space, right, in my women's health clinic. I kinda just tell them, "If you know your shoe size, like, these are things I'm gonna ask you." And it's kinda like to lighten the mood because I know they're scared. They've never had to tell me like, "Oh, like, I should be aware of my LDL. I'm young, I don't have a history of heart disease." And so to kinda lighten the mood, I'm like, "Okay, like, what's your shoe size?" Like, "What's your bra size?" Like, you know that. So that's kind of how I start pretty gently because I now realize like having to see a specialist is it's actually very scary. And I never used to think of it that way. It was just like, oh, it's another clinic visit. So I try to be as like gentle as possible in that first visit.
Let's dig into when you talk about the first stress test, sometimes can
Yes.
be pregnancy.
Yes.
A lot of people, and I've seen this in my clinic, where I'll just share it, a woman who was 4 weeks postpartum, had a healthy baby girl. And she came in, and this was actually during one of my urgent care shifts. So I was brand new to her. And she came in with some shortness of breath, some swelling in both legs, and just had not felt well. And I remember asking her, I said, did you have high blood pressure during your pregnancy? Anything else? And she said, yes. But immediately, I was thinking peripartum cardiomyopathy. I'm like all of these things in the back of my mind.
Yeah.
And that's not talked about enough. Can you share a little bit
Mm.
about that? Like a woman who the risk factors for heart disease after pregnancy.
Yes. So, peripartum cardiomyopathy is considered to be quote a rare disease. And I obviously am a little biased. I see women, I see peripartum cardiomyopathy. So to me, it doesn't seem so rare. I think we do miss it a lot because we're not looking for it. And you can be diagnosed with it, up to 5 months, some women later after you've already delivered. And so that feeling of what you just said, shortness of breath, swollen legs, difficulty breathing when laying flat after you've already delivered. It's like, well, why do I feel like this? And sometimes it can be peripartum cardiomyopathy, which is basically, you've developed heart failure from pregnancy. I think we now know that there may be like some genetic predisposition. But if it's missed, you could go into a heart failure exacerbation, which, you have to be hospitalized for. So I think number one, a lot of people in medicine who maybe don't see pregnant women aren't thinking about it, but it's all of our responsibilities. Like I don't primarily see pregnant women, but I'm going to come across that patient with a history of peripartum cardiomyopathy. Our ED doctors, all it takes is, you just take that, bedside POCUS, probe, you take a look, even one view, really, you can see that, oh, like the ejection fraction's low. This patient should be treated or referred to heart failure clinic, etc.
And when I shared that story, I remember her telling me she just thought it was stress, being a new mom. And that was the big thing. And that kind of leads me to for anyone who is wondering, well, I might just be feeling stressed, even though I might be having chest pain or any of those things. Can
Yes.
you walk us through how stress can impact your health, your physical health, including your cardiac health?
Absolutely. So, so many women hear this, like, oh, you're just stressed or you probably have anxiety. And sometimes it's not stress or anxiety. You can have stress and anxiety. Um, and those two can coexist. But when it comes to especially like highly stressed moms, the last thing they're going to do is put themselves first, which is very understandable. And so a lot of these, well, why didn't you come in earlier? I stopped asking patients this a long time ago because I totally, I understand like why, especially if you just gave birth, you're thinking about your baby. And so even if you're feeling like this, you're not going to think, it's me. You're probably going to stick it out until you're so short of breath that you have to go to the hospital. And so I do think, stress and anxiety, these things can coexist, but I think there's many women, and I have had a patient who has come to the ER, and this is another patient that really changed how I see chest pain in women is that she came to me after she had a stent placed somewhere else many years ago and moved to California, needed a cardiologist. So I'm seeing her in my clinic, I'm asking her her history, and she says to me, you know, you guys saved me. And I was like, well, what do you mean by that? And she was like, Black doctors, you guys saved me. She said, I went to the ER after my grandbaby was born, newborn grandbaby, and I was laying him on my chest. And then, I went home the next day and I felt that sensation like a newborn baby was laying on my chest. And I thought, oh, that's kind of weird. And I didn't think anything of it. But then it kept happening over and over. And so she went to the ER and she's like, I feel this sensation. And she's telling the story and they're looking at her like, what do you mean there's a newborn baby laying on you? She's like, no, that's like the sensation I'm feeling. Like, are you having chest pain? No, it's not chest pain. She goes home. She starts feeling it more and more like at rest. And she goes to the ER. She tells me like they get an EKG. It's normal. They check her labs normal. Finally, they're like, this is the second time this woman has come in. They get a cardiologist. And she said, this Black cardiologist walked in and said, ma'am, I think you're at risk for having a heart attack. And I said, no, you don't understand. It's not pain. She said, and she's never forgotten this, and she's not a medical person. She said, My LAD was 95% blocked, and I have a stent. And I thought, wow, most patients actually don't remember that, but that was so significant for her. And I thought, I wouldn't call it chest pain either if you're holding like a new baby just laying on your chest. And so that's when I realized that there are ways that women describe their chest discomfort that is not pain.
You know, I love that because we know that women's health hasn't been studied, and I often give a qualifier so people can understand. Netflix has been around for 30 years. That's the same amount of time that we've been studying women's health. And because of that, when heart health is described or when poor heart health is described,
Mhm.
it is typical symptoms of left-sided pain, jaw pain, but that's not what shows up in women.
No.
And I love that you did that. Where she said, like a baby on my chest. That's
Yeah.
beautiful. And those are the types of um, words that people need so they can really feel like, okay, I know how to embed that. I know what that is supposed to feel like. And so I
Mhm.
can describe it when I see my doctor. A lot of people that listen to me are struggling with autoimmune diseases, or they just had a baby or they're pregnant and they, went through preeclampsia, gestational diabetes, or have the new, no longer called PCOS, polyendocrine metabolic syndrome. I still have to like practice getting that. What would you
Mhm.
say to those people who are wondering about their risk for cardiac disease?
We don't talk about it enough. We really don't. We don't. And every time I get a patient, whether it's a patient that's admitted or a new patient who tells me they have lupus or rheumatoid arthritis, they're usually very young to be seeing a cardiologist. But, somewhere along the way, they had a troponin that was like mildly elevated. They have no chest pain. And I tell them, you're at risk because of the inflammatory condition that your body is in. And when you have flares, we give you corticosteroids. And now we are kind of pushing you into like cardio metabolic syndrome, even if it's just for, that steroid taper, your body feels it. And so I remind these patients, like, please, if you ever feel an inkling of I feel funny, I feel something, I think it's acid reflux, go to the hospital because their risk for developing ischemic heart disease is very high because of that chronic inflammation. And some of the medicines that we treat when it comes to, them having to be on corticosteroids. And so we don't talk about it enough. We really, really don't. And that's something that I think, we should be telling, especially women with, autoimmune diseases.
And speaking of the ER or emergencies, studies show that women wait longer than men to call 911. We also wait longer in the waiting room.
Mhm.
And it's two things. Sometimes it's our own internal where we don't want to feel like we might be causing a scene, but also
Yeah.
there's a bias that plays a role where we are less likely to be taken seriously. So, what would you say to that woman who is having this mental gymnastics or battle with their own mind? What would you say to them?
You have to advocate for yourself, especially if you don't know how to navigate the medical system. There are some patients who I will say, like, know exactly what to say. I'm having crushing chest pain, right? There are some patients who tell me, like, I I wasn't being taken seriously. And then I have other patients who are like, "I was annoying. I kept going up and saying, I don't feel right. I don't feel right. I something's wrong with me. So a lot of it is you just have to be your best advocate. And I feel like that's so cliche, but you really do. Again, take someone with you and have them also advocate for you because our ERs are a mess. And if you're the one saying, like, oh, no, it's okay. I think I'm okay. I think it's this, they're going to go ahead and just like pass over you.
Absolutely. I had a guest on who unfortunately ended up, she thought she had a canker sore on her tongue, and ultimately it was tongue cancer. And she said something very powerful. She just became the squeaky wheel who would not stop. And she kept pushing and pushing as she got
Yes.
dismissed. And so when you share, what you can do in that moment, I think, continue to push.
Yeah.
So, part of being an informed partner when it comes to your own care is knowing that you need to pay attention to the changes that happen over time, whether
Yeah.
it's 20, 30, 40, 50, 60. And heart health isn't something that should be put to the side because, as we just talked about, there are different subtle signs that can pop up. Walk me through, what should a woman do in her 30s? What should a woman do in her 40s? And I'm going to push you to, what should a woman do in her 50s? Just as she's thinking right now as far as how she can invest in her own heart health.
That is an excellent question. So when it comes to your 30s, I think as more doctors realize that, everyone should have some kind of like we should be risk stratifying patients by now. Some people will already know they'll have their LDL, their hemoglobin A1C, and have an idea of whether their blood pressure is normal by the time they're 30. I would argue that if we are screening women for breast cancer at 35 and telling them to get a pap smear at 21, we should just piggyback on top of that and just check that LDL early because we're screening for cancers that, affect women. At the same time, cardiovascular disease is still the leading cause of death. And so I would say if you haven't already established a good relationship with your doctor by age 30, do so, get your LDL, get your A1C, and have an idea of like that profile. By your 40s, if you have had children, you should be asking questions about, okay, if you don't recall, you don't remember, whether you had gestational hypertension, preeclampsia, gestational diabetes, preterm labor, because these are acute issues, but they also can predict your long-term cardiovascular risks. And then by the time you're in your 50s, we're in that perimenopausal menopause. And at that point, women should be understanding that their risk factor for cardiovascular disease is now, kind of equal to men. You're losing that estrogen, the protectiveness of your estrogen, and your risk factors for developing cardiovascular disease, if you didn't already have the conversation at 30 and 40, is now like higher and higher. And the last thing I will say, we tell everyone now, get your LP little a checked at least once in your lifetime. For women, you might actually want to get it checked one more time after menopause because that can also change.
That was fantastic. Break down the LPAs
Yeah.
so people know what that means.
Yes. So LP little a is lipoprotein A. The way I describe it to my patients is that it's a very like sticky particle that is kind of linked to your genetics. So there's not a whole lot that you did to have that number be very high besides be born and inherit it. We can modify it with cholesterol lowering medications. And so knowing whether your LP little a is high or low can actually help you understand, even if your LDL is normal and you're eating well and your blood pressure is normal and you don't have cardiovascular risk factors, you might just be more genetically inclined to develop cardiovascular disease. And so it helps that conversation with your doctor on, do you need to be on a cholesterol lowering medication? Yes or no? And then have the conversation of, okay, if it's high and everything else looks good, we should probably get some imaging. And that's where the coronary calcium score comes in. And if that looks good, then you're probably okay as far as, managing it with diet, exercise, all the lifestyle modification things that we talk about, but also just being aware that I know after menopause, those numbers may change and you may want to consider having that risk stratifying conversation again with your doctor. So you're not necessarily asking, do I need to be on cholesterol medicine? And so those are the patients that we say, okay, let's get a coronary calcium score, get some imaging, and give the patient a better idea of whether or not they need it or not.
And speaking of perimenopause and menopause, that is such a critical time period. And then that transition as well. Is there any tips that someone should look for if they are like right in that middle of the bridge and they're not sure? Like, what should I be looking for?
I think not everybody is going to have like these like jarring symptoms. One thing that I hear a lot in clinic is my heart is racing. I don't know what's wrong with me, and then I'm like, okay, I'm a cardiologist, but like, let me go through your chart. Oh, okay, you're kind of perimenopausal. It's actually, it's normal to have these palpitations. What you're describing is like hot flashes. And I tell them, it doesn't mean that your heart is unhealthy because you're having palpitations. You are going through a normal change, but do not attribute chest pain to, oh, it's just menopause. And so I tell them, if you don't feel right, and a lot of the times, like when I see like women in the ER who are, high troponin, EKG changes, no chest pain, no chest pain. And I say, well, what do you feel? I don't know. I just feel funny. Okay. I take that very seriously because sometimes that's all a woman needs to tell me. And so I tell them, like, if you're feeling kind of funny, you may have a hard time explaining that to the ER provider. But again, like, you don't feel like yourself. Don't ignore that. Oh, and the last thing I will say is sometimes I hear like, oh, like arm numbness, like left arm numbness and pain, like that's a heart attack. And I'm like, some women actually present with like right and left arm pain. And I tell them that is also not normal. And so not feeling right can't just be perimenopausal or menopausal like symptoms. Like you might actually have some kind of cardiovascular event. And so just go to the hospital and at least get that ruled out.
I'm so excited that you've mentioned that because I've seen a lot of patients where, yes, they have perimenopause and menopausal symptoms. And actually, I recently just did a post about it. But two things can be true, which means that your body can have more than one diagnosis. And
Yeah.
as we shine a light, which we should, of course, on women's health and talking about perimenopause and menopause, we can't forget that there are other ailments as well that could be happening at the same time. And so, as we are trying to elevate ourselves and elevate women's health, we don't want to accidentally
Mhm.
lower the opportunities to catch heart health issues or catch cardiac issues, catch
Mhm.
other things that could be associated or exacerbating them. And that part is so important.
Yeah. Yeah.
So, what's one thing a woman could do right now
Mhm.
as she's listening to make an impact in her heart health?
I would say if you don't already know your numbers, and I know I say this a lot. I say this, I don't know, maybe like several times a year I'll make a post about it, but like really truly know your numbers and know if they're normal because, not just women in my clinic, but like my grandma has heart failure. She's like doing well. My grandma's like, what business do I have knowing my LDL? I wish, 30, 40 years ago, my grandma had hypertension in her 20s. And she just shared this with me like very recently. And I thought, I wish I could go back in time and whisper in her cardiologist's ear, like, hey, can you tell her that these numbers aren't normal? And she had no symptoms. So for years, she's like, I didn't take blood pressure medicines. I didn't have any symptoms. And so I really stress, it's so important to know your blood pressure, 120 over 80. That is normal. You should know that. You should know where you fall and have like that trend. The other thing is, know your LDL and know what it is for you, because there are some patients who it should be very low, and for some patients, we're okay with it being moderate. So know your blood pressure numbers, know your LDL, and know your A1C. There are patients, like a good chunk of Americans don't know whether they're pre-diabetic or diabetic, and what is the difference? What can I modify versus what needs to be treated? And so I would say, if you're a woman listening today, please like know your blood pressure, know your LDL cholesterol, and know your A1C, because those are the three drivers of cardiovascular disease. There are many more, but those are definitely like the top three.
Well, and that was going to be my question. What are the three numbers that every woman should know? But what stood out to me as well is you had mentioned that your grandmother just told you that she has high blood pressure. And I think this is a really cool opportunity to highlight something that isn't talked about enough, which is the fact of storytelling, the storytelling of your health, which isn't often passed down from generation to generation. We pass down recipes, we pass down all different things. But the storytelling of what our health entails is
Mhm.
so important. And why? Because first, just like you mentioned, know your numbers, but you want to know the numbers as well of your grandmother. your aunt, because that story can also help you have prevention, which is, so important, but also get treated sooner rather than later.
Mhm.
Before we wrap up, what's one thing that you wish every woman knew? And what's one thing you wish every man knew about heart health?
One thing I wish every woman knew, I kind of talked about this in the beginning, about, you know, knowing that it's preventable. And I say that because it can be so highly discouraging to hear the statistics over and over again. Heart disease is the number one leading cause of death in women. Because the next question is, well, okay, what do we do about it? And I really stress that it is preventable. And I do believe a lot of that power in prevention is in their hands. It's really in your hands. And you might honestly be that like annoying patient, the squeaky wheel, like you said earlier, but you are advocating for yourself because, like, truly, like, nobody else is doing that for you. One thing I wish every man knew, a lot of men won't really take their prevention or their preventative health seriously until like something is really wrong.
Perfect. The reason why I asked that is I saw it just popped up on my feed about when Kevin on stage, talked about prevention. And so that's where that question came from, because that was beautiful,
Yeah.
realizing that, going to the doctor, knowing your numbers, all of those things. For anyone who has been told, let's say they have symptoms, they're having, whether it's chest pain, they just don't feel right, but their labs are normal, what should they do next?
I think for those patients that are saying, I don't feel right and everything seems normal, especially when it comes to chest pain specifically, because we're seeing this more and more as our testing is getting better. We see this a lot, especially in women where they come in, they're having chest pain. It seems to be anginal chest pain. And we say, no, you're fine. You have anxiety, et cetera, whatever. I think cardiologists now are more aware of microvascular disease. And I'm not going to say that microvascular disease only affects women, because I have seen it also affect men, but for majority of the time it affects women. And we are now doing microvascular testing, which is not offered in a lot of centers, but we do it here at my institution. And you don't necessarily need to do it to get the diagnosis, but there are ways to treat it. And so I think if you're not getting that answer, and I say this a lot, you just get a different doctor. It's not always fair for me to say that because not everybody can, but I think more cardiologists are aware now that microvascular disease can affect somebody that is like coming in with chest pain, it's anginal, relieved with nitrates, and then getting a stress test, getting an echo, getting a coronary angiogram, and having completely normal vessels. And so for those patients, you may need to refer them to a center that does microvascular testing, because they might have microvascular dysfunction, endothelial dysfunction, which is all kind of under the umbrella of small vessel disease.
That was a wonderful answer. That's
Yeah.
going to allow people who are right now at crossroads and they've been told everything is normal. They know they don't feel well. And this gives them an extra step, an extra test that they can ask for when they see their doctor. With all the great things that are happening in health, we've got a lot of things happening, but I always like to lead with hope. What makes you feel hopeful when it comes to the cardiology space, when it comes to healthcare? What brings you joy and hope?
Truly, a cardiovascular disease in women, for a while, the trends were going in the same direction. Men and women's cardiovascular disease was slowly getting worse and worse and worse. And at some point, men's cardiovascular disease started like decreasing and they were doing better. And women's was still going up. And I look back, like mid 2000s, where like the trend started kind of dropping again. And we're going in the right direction. And that gives me a lot of hope. I think a lot of it is back in the 1990s, women cardiologists said, I think we need women heart centers. And the NIH said, yeah, okay. What can we do about it? And they said, well, why don't we start including women in clinical trials? And so those two things, I think, have made a huge difference, that women are being included in clinical trials. There are some studies especially in cardiology, where when you look at the demographic, sometimes it's like almost 50-50. I'm happy when it's like 70-30, at least they included women. But it's our trends are going in the right direction. And that gives me so much hope because even I can get discouraged when my patients are like, I have family history of heart disease, my grandma, my great grandma, my mom. And it's like, oh man, like this patient feels like now it's them. But I really, I'm hopeful. I'm hopeful that the trends are finally going in the right direction.
Yes, I love it.
Yeah.
Well, Dr. Kuria, thank you so much for joining me today on the show. You were an incredible guest. You left so many gems that are going to help so many women know what they can do to advocate for themselves and also know that there are steps that you can take. And I love that you mentioned, baby on your chest. Like those are things that will really help whoever is listening right now help themselves or their loved ones. So you can check out Dr. Kuria on all socials. Of course, we'll have every single way that you can get in touch with her on social media in the show notes. And if there's one thing I hope you take away from today's conversation, it's don't ignore the changes in your body and don't be afraid to ask questions because you know yourself better than anyone else. You've got this. Thanks for listening to Beyond Clinical Walls. If you learned something new today, please leave us a review on Apple Podcasts or Spotify. It really helps us reach more people who could benefit from these insights too. Hit subscribe so you never miss an episode. We've got amazing content coming, including great episodes with the health creators you love.
You've heard the truth, now take the lead. Stand for yourself, know what you need. One step closer, you've made your mark. Keep showing up and light the spark.